Live from our studios, just steps from the fabulous Las Vegas Strip, it's the Business Lounge with your host, David Wright.
Hi, I'm your host, David Wright. Welcome to the Business Lounge. With me today, I have Dr. Bruce Barton. We're going to be talking to Dr. Bruce here about a couple of things. The first one being what residency is like, especially in today's day and age. Then we'll be talking about 3 things that affect women's health. Dr. Bruce, welcome to the show.
Thank you. It's nice to be here.
So before we get started with the show itself, I always ask people to talk a little bit about themselves, and I know a couple of things about you. So I know you're a doctor, I know you're a humanitarian, I know you're a bit of a techno geek, I know you're a dedicated father and grandfather. So tell us about that.
Oh gosh, trying to integrate all those things is a chore. And I have only been able to be successful because of my good wife. Training, the time it takes is quite demanding on the time. So to be able to get all that into focus is a challenge, which I think we've done okay with.
Yeah, I think you've done an excellent job, actually. So looking at, I have talked to you on several occasions. I often joke that you're my neighbor without being my neighbor. You spent about a year and a half in South Africa, really getting out and helping people with health issues. What were a couple of the things that resonated the most with you?
Oh, a couple of things. Number one was the differences between our country and the African countries. It is night and day what we have available to us here and what is available to the great majority of people probably on the planet, but mainly in Africa, where some of the most underdeveloped countries in the world are. The Democratic Republic of the Congo, for example. Challenges with healthcare systems, learning about them, guiding people to appropriate places was a challenge.
How is the infrastructure compared to, say, the United States or even Nevada's infrastructure? Was it difficult getting around?
It was. You have more infrastructure here than I noticed throughout all of and basically I was in the entire southern part of the African continent, about almost 2/3 of the continent. In some of the larger cities, the infrastructure is okay. But on a scale of 1 to 10, if we're a 10 here, they would be about a 4 to a 6 there. Things are aged because of the political system and the changes. They're having a difficult time.
When people think about Africa, and a lot of times people say, well, you're African. What was one of the things that you noticed about the populace itself? How diverse is that populace that you ran into?
It was very, very diverse. I was unaware of the history of South Africa in particular, the settlement there being from the Dutch people, French people, really throughout most of Southern Africa. So there are a lot of Europeans there as well as the original people from Africa.
So looking to move a little bit beyond that and looking at what drew you there was the fact that you were a doctor and you oversaw basically the southern part of Africa. But in order to get to that point, you had to do, which I always have been intrigued by this. That's why this residency. Yes. I've seen examples of it on television, and it can't compare to the real situation. So tell me a little bit when you almost graduated from college, because you got to do your residency, but when you got to the point where you were ready to do your residency, what were the thoughts that you had? What was going through your mind at that time?
Well, first of all, I had to choose what I was going to do. And I chose obstetrics and gynecology because typically there is a happy result involved there. There is a lot of surgery, so procedural things to do. And I did not particularly care for prolonged chronic health care. Typically, ladies are generally healthy, and that's why I picked that. So that was the first thing. And then the second thing was, of course, applying to the residency programs and getting accepted to one of them. And those have changed dramatically over the years.
Okay, so when you say they've dramatically changed over the years, and we're both old guys, but but when you first entered that field to where it is today, what are the major changes that you've seen?
Well, the length of time the residency is 4 years. That has not changed. But in the late 80s, some laws were passed to protect the public, limiting the number of hours that resident physicians could work in a row and how many hours a week. That happened after I finished residency.
So you got to do the 80-hour a week, right?
Well, no, it was more like 100 to 110 hours.
Ouch.
We were on call every other to every third night, which meant a 24-hour shift. If you were able to catch a couple hours in there, you were doing well, and then work throughout the next day. So it was a challenge. I'm glad that I'm finished with that.
Finished and moved on. When did you realize that you were going to make it? What was the turning point when you said, hey, I know I'm going to make it through this residency?
You know, the internship year is a year in which you do multiple different things. You do some orthopedics, some pediatrics, some obstetrics, some surgery, internal medicine. That went pretty smoothly. Getting into the second year, when the schedule became really more difficult and you were all the time either on labor and delivery or on the ward in the hospital or in the clinics, that second year was the most difficult. So when we finished that year, I thought, I can see that light at the end of the tunnel, and this is going to work, and I'm going to survive this. I think it was after the second of the 4 years.
Okay, second of the 4 years. So now that you've been a doctor, and there's been a lot of focus when I was growing up. I'm a child of the 60s, so going through that process, there wasn't the emphasis on women's health there is today. And I know there's a lot of controversy right now. One of the things that was just recently in the news was about mammograms and what age that should start, and whether they're going to be effective or how effective they are. Talk to me, give me 3 things that you think women should focus on, just a quick overview, and then we'll go back and look at those a little bit in depth.
Preventative medicine, I think, is the way to go. So in order to prevent some of the unfortunate things that can happen, such as cervical cancer, pap smears are just really, really important. Since the advent of the pap smear, we've seen cervical cancer just nearly drop dramatically. But if you're not doing them, you can't catch it. Mammograms, I realize there is some, there's some controversy about that, and I suspect within a year or two the recommendations will change again. Even recommendations for self-breast exam are coming under scrutiny, whether they're valuable or not. But I would encourage all women to do a self-breast exam once a month, not while they're having their period, right at the end, and encourage regular pap smears and then a regular visit to your doctor for an exam. Things, if caught early, can be taken care of much more easily.
Okay. Let's go back, since it's just recently been in the news, about breast screenings.
Okay.
There was some thought early on as 40 years old, and then some people said 50 years old, once a year, once every couple of years. What would you recommend a person do at this point in time?
Well, I think one thing that comes into play here is family history. Certainly, if a lady has a family history of breast cancer, then I recommend yearly visits to the doctor. I would recommend mammograms starting at the age of 35. And in that family history, if you have a couple of sisters that when they were 32, they got breast cancer, don't wait until you're 35 to be looking into the problem. Go see your physician and follow the recommendations. Mammograms, there was some debate whether the radiation could potentially cause breast cancer over the years, when to start those. The breasts are actually too dense to see too much before the age of 35 to 40. And so that's why I think the recommendations have gone between 35 and 40, because now you can see some things, whereas before you couldn't. And then whether they follow that up with ultrasounds, of course, is a decision for your physician to make. But I think a good general recommendation, self-breast exam. If you find any lumps or bumps, get to see your doctor. And then without a family history of breast cancer, probably mammograms starting at the age of 40 and annually thereafter.
Also, understanding one of the vital things for a full-term delivery of a baby is nutrition. And I know sometimes women try and neglect that nutrition, or they don't eat well because they're concerned with the weight gain during pregnancy. What would you tell a lady that's concerned with that weight gain during pregnancy?
Well, not only do they not eat well because they may be concerned about the weight, they're not feeling well at all too. So some of that may have to do with that. I would tell a lady a good, well-balanced diet, no starvation diets, no very low-calorie diets. But on the same token, it is an easy thing to gain too much weight in pregnancy, which also puts the fetus at risk. Too much weight gain by the mother. So we try to do some nutritional education in what constitutes a well-balanced diet, number of calories, and on the average, that's about 2,000 to 2,200 calories a day.
Okay, so if there was a limit on weight gain, is there a percentage that you use, or is it by you're seeing stress on the fetus? How did you determine a person has gained too much weight?
That depends on how much you weigh going into the pregnancy too. So ladies who are significantly overweight, we aren't too concerned that they should gain 30 pounds or 20 pounds during their pregnancy. They may only gain a few pounds and be okay. But if you start at your ideal body weight, I think a good number to shoot for is between 24 and 30 pounds.
Looking out into the future, I know when my children were born, it was in a birthing room that the dads had an opportunity to participate at that point in time, which they didn't before. They all used to wait out in the waiting room, and they used to smoke cigars, all kinds of things back then.
All kinds
Probably
of good stuff, yeah.
Not usually the best for a hospital environment. So how has the father's participation helped or hindered your job?
Well, most of the time it's been helpful. The more involved a parent can be, both on the mother and the father side, and the more understanding and better the communication is between the doctor, the patient, and the spouse, the better it is. There are some times, however, when sometimes personalities can get in the way, and a father may not feel things are going correctly in a delivery room, whether it is a normal delivery or it's a cesarean section, and then get in the way, cause a little bit of problem. But those instances are few and far between.
So it's actually helped.
It has.
Good. What would you recommend aftercare to be like? I know that my daughter-in-law, we have a grandson. He's going to be 1 in on the 16th year. And one of the things that I noticed right away is all the things necessary were in the room. A big room, lots of equipment. They had what I refer to as a warming tray, basically for the baby coming out. They monitored the baby's heartbeat, the mother's heartbeat. They monitored both in and out. Quite extensive. So how, to me it was like, wow, this is really different. And I know the ladies were all in there. My son was in there. But I was really, really nervous. So how have some of the things changed to ensure full-term delivery and after care for the infant?
When I first started this, we would whisk ladies off down the hall on the gurney like a bull, race contest to get into that delivery room. Things have really changed, as you just mentioned. the accommodations that are there is just like a room in your house. They do have all the equipment for safety there for the babies and the mothers, should that be required. It is all there, but it's more of a home sort of setting, which is very conducive to the bonding the families go through. Another thing that's real important is after that baby is born, what we call skin-to-skin contact with the mom. Lie the baby down on mother, have some skin-to-skin contact, and that heat from the mother is passed on to the baby and is a huge benefit. 15, 20 years ago, boy, we didn't do a lot of that. It was like, dry that baby off, get the baby into the sterile warmer, and so I think we're going back to perhaps a little bit more natural concept, which seems to work the best.
If you were going to sum up the care necessary, what would you tell an individual today that's thinking about becoming pregnant, what they should do during that pregnancy, and then what they should do after the pregnancy?
Well, you bring up an important point here, but we've left out one little thing which I think is important. You don't get pregnant on a whim. You plan for it, and if you have some health-related issues, you need to address those before you become pregnant, because they become much more difficult in the pregnancy to treat adequately, and then they can put the fetus at risk. If you're a smoker, quit. Alcohol is not good. Even one drink a day, even a couple of drinks during the pregnancy has been shown to be very potentially deleterious to the baby. So we need to have some lifestyle adjustment. If you need to lose a little weight or gain a little weight, get to the very best you can to optimize the potential for a really positive, happy outcome. And then during the pregnancy, of course, exercise is very, very important. We used to really shy away from that. Proper nutrition and a healthy home environment. And then after, depending on how the delivery goes and by what method, it can be you're back to normal activity within a few weeks to, it may be 6 weeks. And then there's all sorts of other issues of breastfeeding, whether to do that. Some ladies choose not to. That can have an impact as well.
Okay. So looking at where things are going in the future, if you could predict the future, and nobody can.
Be nice, wouldn't it?
It would be nice. Where do you see your area of study moving to? What are some of the things that are on the horizon that the general public may not know about?
That's a really good question. Technology has done so much just over the course of my career. For example, I remember early on in training, we did laparoscopic surgeries. The general surgeons thought that was a toy, and they weren't doing it. And now look what's happened. The general surgeons and the specialty laparoscopic surgeons, they're doing just about anything you can, even cardiac surgery through these. So the technology is going to change and be very beneficial. As we begin to understand more things that come up, bleeding disorders, blood clotting disorders, autoimmune disorders, perhaps there will be new developments in the field of medicine that will allow us to treat those and avoid some of the catastrophes that happen in pregnancy because of those. But just the technology, and then the hemoglobinopathies and blood clotting disorders are going to be big.
Well, I do want to thank you for being here. We could spend time again talking about specific things. As you told me, you could spend an 8-hour lecture just on one subject. This is just a brief overview. I want to thank you for taking time out of your day. And this is Dave Wright with the Business Lounge, where we talk to real people about real business and real success. Until the next time, be blessed.